A popular question from our doctors is if they should submit a CBCT for a case. Although you can always schedule a call with us to discuss a specific scenario, let's review some general guidelines that will help you decide between CBCT or no CBCT. First thing is that submitting a CBCT will always give you a tailored treatment plan. In this example, we can see no issues on a crown-based treatment. But once we translate that to a deep CBCT case, we observe periodontal compromise. Although our AI is pretty good at determining the best movement protocols for your case even without a CBCT, it can't predict with certainty a specific case's periodontal status, anatomical boundaries, and teeth morphology. This is to say, if you suspect your patient may be periodontally compromised, has a thin phenotype, or has prior orthodontic treatment, a CBCT would be advisable. Also, if you take your regular 2D x-rays, so let's say pano or full mouth series, and you observe unusual root anatomy, we highly suggest submitting a CBCT to prevent the scenario to the right, root collision. When roots collide during orthodontic treatment, the case stops tracking and leads to several refinements, which may not even get you to your intended goal. This is a list that will help you decide when to submit a CBCT with your case. As a rule of thumb, when you're foreseeing that a lot of movement will be needed to resolve the case, in other words, for any complex cases, a CBCT is recommended. Let's quickly go over each bullet. Severe crowding, so more than 8 millimeters of space discrepancy, will require extensive rotations, expansion, and proclination, so we highly suggest you take a CBCT. Another reason for a CBCT is orthodontic relapse. This example seems like a very straightforward case that could be solved with clear aligners. The gingiva looks relatively healthy, and there are minor recessions. Unfortunately, the CBCT shows a different story. The previous orthodontic treatment has caused orthodontic-induced dehiscence, a widespread pattern of bone recession after orthodontic treatment. This was not apparent clinically or on the panoramic. Since this may change the provider's treatment approach, it is best to submit a CBCT whenever the patient indicates they have had prior orthodontic treatment. Extensive expansions, so 2 millimeters or more, should preferably be accompanied by a CBCT due to periodontal concerns. For that same reason, if protrusion of upper and lower anterior teeth is present, we recommend a CBCT. Extensive retraction, also for the same reasons as with expansion, is better treated with a CBCT. The clear example for this will be a Class 2 Division 1 patient who requires overjet correction of 1.5 millimeters or more. On the other hand, if you have a Class 2 Division 2 patient who requires extensive torque on upper anterior teeth for their treatment, a CBCT is recommended because extensive torque can very easily lead to dehiscences and fenestrations. Please note that research indicates that periodontally stable patients can be treated orthodontically. Although we do recommend close periodontal follow-up and more frequent visits, and even a periodontal consultation depending on the case. Regardless, the fact that these patients may have bone recession, which may not be apparent clinically, makes a CBCT imperative. Also, keep in mind that if there is bone recession present, biomechanics will change as the center of resistance will be affected. Since more and more providers are taking a CBCT prior to implant placement, they can make good use of it by offering aligner treatment to the patient to make space for that implant. Before, a case like this will require crowning and maybe even a root canal of that second molar. with a less than ideal result since the implant will not be parallel to the adjacent teeth's roots. In this case, we can make space for the implant, create root parallelism, and save that second molar's precious dental tissue. This particular case took only 4 months to achieve this result. A final word on complex cases. Here we see an extensive open bite case. This case is difficult, will take a long time, and will require refinements due to going outside of predictability limits. Although a CBCT will be needed for it, I highly suggest starting your journey with us. So let's say your first 10 to 20 cases with a simpler case, such as this one. Now, for this specific case, no CBCT was submitted and the result was impressive, achieving 3 millimeters of total anterior intrusion to resolve the open bite in just 1 year. Can you treat the first complex case that I showed? Absolutely. But you and your patient need to be aware of the road ahead. We have a lot of doctors that choose to treat complex cases, but always with a CBCT. Once again, you can make an informed decision based on the guidelines I presented.